Hey there, friends, lovers of medicine, caretakers of critically ill patients. Welcome to the next installment of the Critical Care Survival Guide. We're going to be talking about ventilator alarms. Hopefully, by the end of this short session, you'll have a little bit of an understanding of what different things might set a ventilator alarm off. Ventilator alarms come in 4 different flavors: low tidal volumes, high peak pressures, disconnection, and apneas. Let's go through each one in turn. I want you to understand there's sometimes when you really need to react and address a problem. There's other times where you can hit the snooze problem, make a small change, and move on. Understanding the difference between those two things is critical for you to do well in the intensive care unit. So for starters, let's talk about low tidal volumes. Low tidal volumes can be seen from a variety of different things. A leak of the cuff, that's the cuff that is inside the trachea that prohibits the air from leaking around the endotracheal tube. If that cuff is broken or if it has a leak, the vent's not going to register the tidal volume accurately and will read as a low tidal volume. That can be assessed through physical exam by listening to the neck or by looking at the screen on the ventilator, and it'll tell you the tidal volume in versus tidal volume out, and you'll look for a discrepancy there. It can help you pick up a cuff leak. Next would be biting. If the patient's biting on the tube, or perhaps it's kinked and the patient's turning a certain way, the volume's not going to be able to get in, the low tidal volume alarm will probably go off, and as you'll come to find out, the high peak pressure alarm will probably go off as well. Same applies to coughing. What are peak pressures? That's the next type of ventilator alarm that you might see. Peak pressure is the highest pressure that air encounters as it moves into the patient. Okay, so things that elevate the resistance of air moving into the patient will elevate the peak pressures. Things that commonly elevate the peak pressures are things that obstruct the endotracheal tube and the large airways. Biting, kinking, as we just talked about, but in addition, mucus plugs, asthma with severe bronchospasm, especially in the main airways, would be other causes of peak airway pressures. One quick way to assess if that is the problem is seeing if you can pass the suction catheter through the endotracheal tube. If the suction catheter doesn't pass, now you have to expect there might be a kink in the back of the throat that you can't see, or something further on down. The other great thing about the suction catheter test is you can suck out a potential plug or something else that might be causing the problem. In addition to high peak airway pressures resisting airflow into the patient's lungs, the other thing that can affect the peak pressure is the stretchiness of the lungs, or the compliance. I just told you that the peak pressure is the highest pressure that air encounters going to the patient. Well, the compliance, or the stretchiness of the lungs, while it can be elevated, it's never higher than the peak pressure. The compliance is assessed at the end of inspiration. It's the end inspiratory pause pressure. So we blow the lungs up with air and we pause the ventilator and we see, okay, what's the pressure right now? It's a measure that is the compliance, the equation for which is the tidal volume divided by the change in airway pressure. Things that can increase the compliance in your patient acutely would be pneumothorax, especially tension pneumothorax, which prohibits expansion of the lungs. More chronically, or over some time, you could have evolvement of pulmonary edema or evolvement of ARDS. Both of those things will affect the stretchiness of the lungs. What about vent disconnect? If the ventilator gets disconnect, be ready, because a very, very loud alarm is going to go off, and nurses and RTs from all over are going to go rushing into the room to try to rehook the ventilator back up. That'll be an easy alarm for you to detect, and the simple solution is just to reconnect it. Lastly, let's talk about apnea. When we have patients on ventilators that are on a set rate, you're not going to see the apnea alarm go off. But when we have patients on ventilator modes that are spontaneous, meaning the patient is needing to trigger the breath in order to get a full breath volume, then you might have the apnea alarm go off. Modes that might predispose to apnea would be something like volume support or CPAP with pressure support. Both of these modes require the patient to initiate the breath. Things that might prohibit the patient from initiating breaths most commonly would be sedatives, but in addition we have hypoventilation syndromes. These can be seen with strokes. They can also be seen with, as you know, the obesity hypoventilation syndrome. And finally, if the patient's too weak to even trigger the breath, then the vent won't give him the breath. Triggers can be flow or pressure triggered. You can talk with your RT about whether or not the trigger might be sensitive enough to detect the flow of breath air into the patient in order for them to get a tidal volume. Alright, so ventilator alarms come in a variety of different forms. I hope that this short tutorial will help introduce you to some of the things that might cause a ventilator alarm to go off.
Dr. Grant.
Yeah, what's up?
Patient in 2130?
Smith?
Yeah.
Yeah, what's going on?
The vent keep alarming and I don't know what's going on.
Well, did you examine the patient?
Yes, I did.
Anything wrong?
Nothing. Equal air entry. Laterally.
What's the plateau pressure? Is it okay?
Fine.
Less than 30?
Yes.
Huh. Did you pass the suction catheter?
Yes, I did.
Passed easily?
Smoothly. No
Lots of
problem.
secretion, stuff like that?
Yep.
Not wheezing?
Nope.
Did you talk to the respiratory therapist?
Yes.
What do they think?
He doesn't have an explanation. For
Doesn't
that.
know. Is it an apnea alarm or is it a pressure, high airway pressure alarm or does it say?
No, it didn't say.
Huh. So the patient's stable,
Yeah.
x-ray's good,
Yes.
and suction catheter passes, and this thing just keeps freaking alarming on you.
Yep.
Unplug it.
Will do.
Okay, see ya.
Bye.